We've seen some very encouraging results about immunotherapies, the anti-PD-1 and now anti-PD-L1 immunotherapy approaches in previously treated patients, some extensively pretreated, and they work in some patients and can be very tolerable. And a question is where best to put them. Should they be a second, third, fourth line therapy? Should they be combined with chemotherapy? There was a report here of the feasibility of combining with chemotherapy that looked very promising in small numbers of patients. And I don't know that it makes sense to give an immunosuppressive therapy with an immunotherapy, but we'll see. But do you think there's a best place for them in terms of later therapy, first line with chemo, potentially replacing chemotherapy in the post-chemo radiation consolidation setting or post-surgery for early stage? I mean, how do you see these best being positioned?
Well, I think in my own mind, the potential of immunotherapies is this could be the replacement for any other treatment. If they truly pan out, because your immune system doesn't go away, and the immune system is highly adaptive to changes. And so if they truly pan out as being effective and durable, like years durable, then it would be hard to argue that you should wait to give someone that up front. I think we still have a lot to learn about how best to use these. I think there's some preclinical evidence that, for example, the PD-L1 can be induced by certain things. So maybe you should be giving someone chemotherapy ahead of time to try to get the expression up, even though you're suppressing the immune system, and then you could sequence it with that. I'm just kind of thinking out loud here. I don't know whether that would actually work or not, but there probably are ways we can get creative to make this effective in a larger number of people. I think in the adjuvant setting, this is incredibly exciting because we know that a large number of these people have metastatic disease and we just can't detect it, but they're eventually going to relapse and potentially die from their lung cancer, but the immune system can see them. So if you could use that resected tumor, figure out what the best therapy was, and then use it in that setting, I think it would have tremendous potential. And similarly in stage 3 patients, where we've got really microscopic metastatic disease that we can't detect and we can't effectively treat.
But these patients are very high risk, obviously.
Obviously, yeah. I mean, the majority of them do have metastatic disease, and we just don't have effective enough treatments to prevent that from showing up. But if we prove that that's effective, then I would say that would be my preference, I think. And I think patients really like the idea that this is something that their own body is doing to fight off the cancer as well. So that would probably be their preference.
Mary, what are your thoughts about where these might best be integrated?
I actually believe that we need to move them earlier. And, you know, the immune system of patients who have had multiple treatments and who have low albumin and are malnourished is really not in a position to respond as well to these drugs as someone who's newly diagnosed and still has a good performance status. So I actually think that we're probably going to see the most benefit by moving these drugs earlier in our lines of treatment. I also think if the promise pans out, could have tremendous implications for adjuvant and locally advanced patients. I would love to see a trial with immunotherapy and some sort of sequence of immunotherapy and chemoradiation, because there's some very interesting data that radiation itself induces an immune response. And so that you may be able to augment that by treating with one of these drugs. Mm-hmm. So I would love to see earlier studies. I'd love to see, I think we could learn a lot by doing studies giving patients either immunotherapy or combinations of chemo and immunotherapy prior to surgery, so that we can see what happens to their tumor and get some biomarkers after surgery.
That's an interesting window of opportunity approach.
I would love to see that.
Yeah.